So the next presentation will be another international presentation by Bendix Carstensen, coming from Denmark. Thank you very much for accepting the invitation of the PhD students. He is a senior statistician at the Department of Clinical Epidemiology at Steno Diabetes Center. Steno Diabetes Center is a hospital, research and teaching center dedicated to treating and managing diabetes, located in, Gentofte? Gentofte? How do you spell it? In Denmark. He is conducting research projects on the demography of diabetes, concerning occurrence, mortality, and so on, mainly based on registered data or large cohorts, so clearly epidemiological approach. And his current areas of research in biostatistics are analysis of follow-up data from registered studies and demographic databases, comparison of clinical measurement methods, and multi-state models. And you see in this presentation, this is clearly an example of a multidisciplinary approach of diabetes. We had urbanism, genetics, and now we have more statistical approach. I think all these presentations are very important.
First of all, I should say a little bit about Steno Diabetes Center. Gentofte is just a suburb of Copenhagen. So this is effectively Copenhagen. This is both a clinic and a research institution. The number of employees is about 200. About 100 of them are in research, and about 100 of them are in the clinic and in the clinical laboratory, etc. It's about currently 6,000 to 7,000 patients associated with the Steno Diabetes Center. They come anywhere between 2 and 5 times a year, depending on how the disease is panning out. This is a very inspirational place to be because I not only have epidemiological colleagues, but I also have some very essential clinical colleagues. So whenever you talk about a relevant topic in diabetes, it's always a very nice corrective to have persons who actually see patients every day, who can tell you that it might be academically very interesting what you're proposing, but it's totally irrelevant in general practice. So, I have been working with the Danish registers. You might know that in Denmark everyone has a person identification number, which is used for everything, from salary, bank account, to healthcare, wherever. And we have registers of diseases where all cases of disease are registered. The oldest register in Denmark is the world's oldest cancer registry. So we have a registration of all newly diagnosed cases of cancer in Denmark since 1943. So, a brief overview of what I'm going to say. I'm going to say something about diabetes incidence in Denmark. I will say something about mortality among diabetes patients, and also the mortality relative to the general population. I will say something about cancer occurrence among the diabetes patients in Denmark, and also how this, and in particular how this cancer occurrence is relative to the cancer occurrence in the general population. And I will say something about the relationship between cancer and diabetes in absolute terms. So it's not only about how cancer occurrence is relative to the population, or to the cancer occurrence in the general population, but also how these two diseases actually occur in total in the population. So that's basically talking about the lifetime risk of these. The Danish registers that I will use here is the National Diabetes Register. It is complete from 1995 and onwards. So that is, in the register will be everyone who was a prevalent case of diabetes at the beginning of 95, and from then on, everyone who has got a diagnosis of diabetes. I should say, this is an administrative register. So it's based on other registers. It's based on the National Patient Register. So if you have been in a hospital or a clinic, and there has been put down a diagnosis of diabetes, you will be included in the register. If you have, it's based on the prescription register, so if you have taken out a prescription at the pharmacy for oral anti-diabetic drugs or insulin, you will be in the register. If you, and it's based on the health services register, so there is a health service called food therapy for diabetes patients. If you have had one of those, you'll be in the register. And finally, and this is a somewhat debated point currently in Denmark, if you have had 5 blood glucose measurements in the course of 1 year, you'll be in the register. This is debated whether this is overdiagnosis. The other register we are looking at is the Danish Cancer Registry and the cause of death register. So we know we have a register when everybody dies in Denmark. So the incidence data sources are the National Diabetes Register, where we have the date of diagnosis of diabetes, date of birth we have, and we also have the date of death for these people who are in the National Diabetes Register. I should say that currently there is about 400,000 people in the register, and of those, approximately 100,000 are dead. So the current number of diabetes patients registered in Denmark is in the vicinity of 300,000. And maybe I should mention to you that the population of Denmark is 5.5 million. So it's pretty much 10% of the French population. From Statistics Denmark, we have the population size by age and date. We have the number of deaths by age and date of death. And so, based on this, we can compute the number of diabetes cases and person years in 1 by 1 year, age by date case. So when I say person years, it's a little complicated, because if you want to describe, say, the incidence rates of lung cancer, you can just take the lung cancer cases and relate it to the Danish population. Because the number of people in the Danish population with lung cancer is quite small, because it's not that frequent a disease and it's very lethal. This is not the case for diabetes. In the ages 70 to 80, we have a prevalence of diabetes patients of about 20%. So if you want to say something about diabetes incidence, you cannot just say the number of diabetes cases relative to the general population. You will have to say relative to the general population who doesn't have diabetes. So you have to take the diabetes register and enumerate the person years lived by the diabetes patients, and then subtract that in order to get the person years lived by people without diabetes, that is, among the people who are at risk of having a diagnosis of diabetes. So this is what is meant in this slightly cryptic statement. So now, for every combination of age and date in one of the classes, we have we have the mean age and date as continuous covariance, and we have the number of cases and person years. And what I have done is that I have fitted a so-called age period cohort model with smooth effects of age. So we believe that diabetes occurrence depends on age, and of course it also depends on calendar time, as it's dramatically changed by time. And also, if you subtract those two, we also take into account date of birth. It turns out that the effect of that is quite minimal. So when you report these models, what you get is that we show age-specific occurrence rates of diabetes for a given reference. You have to fix some years. In this case, I have fixed it as year 2000. And we have calendar-specific rate ratios relative to year 2000. And finally, we have some birthday-specific residuals of the cohort effects. It's been shown you could interchange these two if you wanted, but I've chosen to use these ones because they have they show the smallest effect. And this is what they look like. So the blue curves are men, and the red curves are women. So these are the age-specific incidence rates. And you can see it looks as if women have a higher diabetes occurrence in the age from, well, basically 20 to 40, say the fertile age. There's a peak of incidence around age 80. And over here is the cohort effect, it's pretty flat. And here is the effect of calendar year. So this is the reference year 2000, and you can see there's a dramatic increase. I don't expect you to be able to just tease out what the slope of that, sort of the average curve, slope of that curve is, but I can tell you the average slope of that is about 4% per year. So the incidence rate of diabetes in Denmark increases some 4% per year. So that is pretty straight down here. This is a different curve. You can see they look pretty much the same. As I told you, there was some debate as to whether to include this inclusion criterion of having 5 glucose measurements in a year. And it turns out that if you sort of don't use that criterion, you get sort of slightly fewer diabetes patients, and some of them diagnosed slightly later. And this is what it looks like if you do that. And particularly you can see that the female excess incidence in the fertile age goes away. And it's very clear when you look closer at the data that there is a lot of women who are pregnant who are under the suspicion of gestational diabetes. And the way to check gestational diabetes is to make a lot of blood sugar measurements. So there clearly, in this piece here, there is an artifact, diagnostic artifact. You can't really trust the figure. Then you can see it looks pretty dramatic, but it is in an area where the incidence rates are quite low, so in absolute numbers, it's not massive. But we are looking at, if you exclude this criterion, the number of diabetes patients in the register would be lowered by some 15 to 20%. So the increase in incidence rate is about 4% per year, and the incidence peaks between 75 and 80, where the incidence rate is 1% per year. So maybe I shouldn't say 1% per year. I should say it's 1 case per 100 person years. That's the maximal incidence rate there. And the incidence rates are generally higher for men than for women. And we see very similar time trends for men and women, 4% per year. If we go to mortality, what we do then is to compute the number of deaths and person years among diabetes patients in 1-by-1 year age-by-date classes. So that gives us the mortality rate among the diabetes patients. From Statistics Denmark, well, okay, in order to try this, we use the mean age and the continuous covariance. And we do the same as before, for some of the smooth effects of age, calendar time, and date of birth. This doesn't mean this is a typo. So what we get is exactly the same as before. Well, it's not exactly the same as before, but the same layout as before. We get age-specific mortality rates for some reference year 2000. We get calendar-specific rate ratios relative to 2000. And we get some birthday-specific residual rate ratio. And this is what it looks like. It looks a little messy. And that's because I've taken the age range from 0 to 40, included that, which is kind of stupid because the number of deaths before age 40 is tiny. So there's virtually no information happening, so this is just noise. But you can see that among the diabetes patients, mortality among men is higher than among women. That's not a surprise. The mortality increases. This is a log scale, and these are approximately straight lines. So mortality increases exponentially by age, as it does in the general population. There's no cohort effect, and you can see the calendar time effect here is virtually identical for males and females, and it is decreasing. And the decrease is approximately 4% per year. So incidence increases 4% per year, mortality decreases 4%. Well, these two numbers are not at all related. So the decreasing incidence rate is 4% per year, mortality rate increasing exponentially by age, as do population with Pascale, as do population mortality. So let me say something about, you see, the title of this talk was something with multiple timescales. And actually you have seen multiple timescales. Because what we have here is people get older. So this is a timescale. Well, calendar time advances. So this is a timescale as well. This is not a timescale. Calendar date of birth is not a timescale. We all have the same date of birth throughout life. So that doesn't change. But our age and the calendar time in which we live changes. So this is a way of looking at the rates as cross-sectional rates. So this is really not, you could say this is not, may not be correct, because these age-specific rates here are not directly interpretable as rates you could imagine a cohort of people would see through their life. This is the rate you see for everyone who's alive in year 2000. But you could do it the other way, actually, do this. So this would be more like longitudinal rates, where you can see that if we now refer to the 1950 generation, so these will now be the diabetes occurrence rates that you would see in the 1950 generation. It's the same model, it's just a different way of showing the rates. So this is taking, so for the 1950 generation, so this would be the incidence rates among 40-year-olds in 1950. Forget that. This would be the incidence rates among 40-year-olds in 1990, because it's among people who are born in 1950, and when they are 40 years old, the time is 1990. And so this would be the incidence rate among 60-year-olds in 2010. So this will sort of, this curve will correspond to the same generation of people. So we take people born in 1950 and see what goes on with them. So this is, you can say, this is more realistic. Now the problem with this is, of course, that it's also, to some extent, an extrapolation, because we only have observations from 1995 to 2012. So we only have 18 years worth of observation. So I sort of misled you by just accidentally pointing to some of those 18 years where we do have observations. We don't have observations for the 1950 generation down here, and we don't have observations for the 1950 generation up here, because the 1950 generation, they're not 90 years old yet. But you can see, because we have increase in incidence, the longitudinal curves are steeper. It's not quite the same. I'm sorry, I apologize for that. It should have made it the same y-axis. The y-axis on this is slightly longer. So the slope is actually quite a lot steeper. So this is the squeeze you're in when you have two different time scales. You have to report them either way. If we look at mortality among diabetes patients, there's actually three time scales that are of interest. There's the age, of course, there's the calendar time, there's also the duration of diabetes. It would be crazy to tell the diabetologist that the mortality among diabetes patients only depends on the patient's age, and not at all whether he had had diabetes for 3 years or for 30 years. But it's sort of meaningless to report the timescale separately, because when you have a regression model with several variables in it, and you report the effect of one of them, you're implicitly saying, this is the effect of, say, BMI, assuming that age and blood pressure, whatever, is the same. We assume that this is the same for all of them. But that's sort of goofy when you're talking about age and duration of diabetes. Because if you have a person current age 40, then you say, well, you have also a patient current age 45. If you want to make a sensible comparison of that, as if it was a person that was aging from 40 to 45, it doesn't make any sense to say, in both of these cases, we have a diabetes duration of 5 years. It would be much more sensible to say, we have a person age 40 with diabetes duration of 5 years. And the relevant comparison to that would, of course, be a patient age 45 with diabetes duration of 10 years. Because then you would refer to the same sort of person. The question is, although the problem is, of course, that it gets a little more complicated to report. Because then you have to say, okay, we will start out with patients who are diagnosed at age 40, and then separately we have to show what is the mortality for patients who are diagnosed at age 45, at age 50, so you get more splits. But this is what it looks like. So I figured this model where I have an effect of age, current age, diabetes duration, and calendar time. It's still blue is men, red is women. So I'll explain to you what this means. So we're looking at people diagnosed in 1996 in different ages. So this here is the mortality among diabetes patients aged 30 at diagnosis. And then you follow them for some almost 20 years. So it's a little bit of an extrapolation. So this is the mortality rates for diabetes patients, men, who are diagnosed at age 30, and how the mortality pans out as they age, and as the duration of their diabetes increases. And this is for persons who are men diagnosed at age 40, and how it pans out. For men aged 50, etc. And the same for women. So what you can see is that diabetes duration has an enormous effect on mortality. It's very high just after diagnosis. The mortality actually goes down even if the person is actually age, and then it sort of starts to pick up as someone ages. This is, of course, nothing to do with the disease. It's not a biological effect. It's a diagnostic artifact. Because when you have people who are newly diagnosed with diabetes, there's a very large overrepresentation of persons who have been diagnosed with diabetes because they suffer from something else. For example, my clinical colleagues will say that if you want to look at diabetes incidence after heart disease, it's going to be totally rubbish, because anyone who comes to a hospital with heart disease will immediately be tested for diabetes. And this is the sort of thing you see, that there's a very large proportion of people, so if you're very rude, you could say, there's a large fraction of the newly diagnosed diabetes patients who are about to die anyway. And that's the reason for having diabetes. So this is what you see. But this is the way, this is the only way you can report the joint effect of two timescales. Right. So this is what we see. So we see mortality increases, but it increases in a slightly odd way by diabetes duration. You can also look at the relative mortality. You can see how is the mortality among the diabetes patients relative to the general population. And that, of course, can depend on age, calendar time, duration of diabetes. And it turns out when you do this analysis, it's very simple, similar to mortality analysis. I'm not going to go into the details, but those of you who are statisticians will know that you basically just replace the person years with the expected numbers. The same analysis. And this is what it looks like. So there's no difference between men and women, so there are only curves that are similar. And this is for people who are diagnosed at age 50, and at age 50 diagnosed, the relative mortality relative to the population is sort of like 4 times as high, and it goes down and it ends up being like twice as much. But if you're diagnosed at age, say, 70, the relative mortality to the population ends up being in the vicinity of 1.3. So if you see publications where people have looked at the SMR, the relative mortality relative to the population, you will typically see that people say the mortality goes down by age. And this is because they have sort of averaged over these occurrences. But for individual, and this is true for the general diabetic population, the general diabetic population age 80 has a relative mortality which is smaller than the diabetic population age 50. But if you look at it as individuals who have a specific age of diagnosis, it is so that shortly after diagnosis, it is so that the relative mortality of those diagnosed at age 57 is pretty constant through the rest of their life. So this is how the addition of an extra timescale adds a little bit to the understanding of what goes on. I said I was going to say something about cancer occurrence. So you would like to, you might, it's well known that diabetes patients have approximately 10 to 20% higher incidence of cancer. The first study was by Swedish people back in the mid-80s. They produced a number, say 1 or 2. So what we have done, linking the diabetes register and cancer register, is to follow the Danish population. So everyone starts at being well, and you can, during your life, you can get diabetes, or you can get cancer. Now, a diabetes patient could get cancer. In the diabetes register, we also have a registration of the date when people start insulin. And insulin has a particular interesting role to play in this context, because insulin is, among biologists, known as a growth factor. So from sort of a pure petri dish point of view, you would expect that people who are on insulin, they have faster growing tumors, basically. So therefore, it's so interesting to look at people, diabetes patients who go on insulin, and look at their cancer incidence. So basically, it's a comparison of these two incidence rates with this one. And this is the numbers we have available in Denmark. So this is the person years among the well persons. So this is like 75 million person years. You can see 75 million, that's approximately 5 million people in Denmark, followed for 15 years. And diabetes patients have 1.2 million person years here and a quarter of a million person years here. And these are the number of cancers among diabetes patients. So this is what we saw. We're modeling the occurrence rate of cancer among diabetes patients. Well, no. The statistical modeling is essentially modeling the diabetes, the cancer occurrence in these two groups of people. And we model it as a function of age, calendar time, date of birth, and the interesting thing is on top of that general model for cancer occurrence, we put an effect of duration of diabetes, and we put an effect of duration of insulin use. And so this is a type of result here. So this is the effect of the duration of diabetes on the rate ratio of cancer between diabetes patients and the general population. So this is a rate ratio. There's no numbers on it yet. This is about 2. The numbers come in a second. So it looks pretty much like the mortality thing. So everything that goes on, so whenever you have diabetes diagnosis, there is an overrepresentation of people who are bad off in terms of mortality, or in terms of cancer occurrence. And this rate ratio out here after 10 to 12 years is about 1.15. If you on top of that put insulin, so this is the rate ratio of diabetes patients insulin at the date of diagnosis. And then it goes down and ends up here. This is the rate ratio of diabetes patients who started insulin 2 years after diagnosis of diabetes. See, this is diabetes duration. And this is those who started insulin at 5 years after. This is for all of them. So the one to the right here is for women, this is for men. So the full lines are diabetes patients not on insulin, and the dotted lines are diabetes patients on insulin for 3 example times of insulin initiation. And you can see it, broadly speaking, 1, 2, it's about 15 to 20% elevated cancer occurrence relative to the general population for diabetes patients not on insulin. And for diabetes patients on insulin, there are very few of them, but there's definitely some sort of elevation relative to the general population. And it's in the vicinity of 20 to 30%. Incidentally, I should say that Steno Diabetes Center is actually owned by Novo Nordisk, which is a large Danish pharmaceutical company that sells approximately half of all the insulin sold in the world. They were very interested. Right. Finally, I would say something of the overall impact of diabetes and cancer and the population. So the drawing you just saw, yes, okay, the drawing you just saw was rate ratios. So I'll say a little bit about how many are affected by the disease during their life and how this has changed over time. So this is a scenario. You can be well, you can have diabetes, you can have cancer after diabetes, you have cancer and diabetes after cancer. And then you can die. So this analysis is going to take the mortality into account, because I want to see how large a fraction of people who start being born end up having had a diabetes or a cancer diagnosis sometime during their life. So we look at the incidence cases, the person years, and we classify all these rates, all these 9 different rates in 1-year age classes and 5th age period cohort. This is what the models look like. So these are full lines here. Cancer occurrence rates, and these are diabetes occurrence rates. And down here we have the mortality rates among people without any other disease, with diabetes, with cancer, and with both diseases. So we have here, I have basically 9 different age-specific incidence rates or mortality rates, separate from age, so that I can follow people through this diagram. In general, we have that the diabetes incidence rates, these are the 2 top ones here for men and women. You can see they increase about 4% per year. The cancer incidence rates, they also increase, but only approximately 2% per year. Whereas the mortality rates, there are 5 different mortality rates, they all decrease pretty much in the vicinity of 4% per year. So more. So what we do is that we start everyone stage well, and we use the predicted rates, the fitted rates, to move people between these boxes, and then we turn to the next in small intervals. I've chosen the intervals to do the calculation to be 1 month, because it's not really stable if you 2 years or 1 year. And so you can basically just calculate what the fraction in each state is. The statisticians in the audience, they will know that this is absolutely trivial. You just take a matrix. So it's like 3 lines of code to do this matrix multiplication. So basically, we use the estimated rates at 95 out of 2012. So if we use the rates that were estimated as of the 1st of January 2010, this is what we get, men and women. The black curve here is the estimated survival curve, so you can see everyone is dead by age 100. These men, not the population. And what you see here, for example, at age 70 is this many have diabetes and still alive. This many have cancer, still alive, and this many have both diseases. This is the fraction of the original person who at age 70 are still alive without any of the diseases. These are the ones who are dead without any of them, and these are the ones who are dead with the different diseases. So what you see out here at the end is that 100 to 61, that's like 39% have had diabetes diagnosis before they died. And here you see 79 to 28, so that's 51%. So the lifetime risk of the cancer is about 51%. And the lifetime risk of both is about 80%. So this is taking, so if you take the left hand side here and calculate what's the lifetime risk of diabetes, cancer, both, and do it for different years, this is how it has evolved. In 95, the lifetime risk of cancer was a third, of diabetes a fourth. Nowadays, it's 40-something% for diabetes and 50+ for cancer. So, in general, diabetes incidence increases 4% per year, cancer incidence 2% per year, mortality decreases 4% per year. The lifetime risk has increased dramatically for diabetes, for cancer, and particularly for both.